So I farm so hard the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get
What's
paid.
good, fam? It's your host, Jim Pruitt, aka Pharm to the ED, and I'm bringing you another episode of the Pharm So Hard podcast. So we know that quicker and big doses are associated with better outcomes. But I think the other side of this that probably gets a lot of arguments between the cardiologist and the nephrologist is the adverse reactions. So speaking of these, what are the ones that we should look out for? Because I think some people may not think about a few of these.
Yeah, so the biggest one I think that we all think about is really monitoring your electrolytes, especially potassium, right? I always say potassium is going to be your most sensitive and dangerous electrolyte, and that's what's going to kill most patients first, right? So low potassium can cause cardiac arrhythmias. So when we give high doses of loop diuretics, we're going to see decreases in potassium. So you really have to keep on top of potassium supplementation. And in most of our cardiac patients, we really want to keep potassium above 4. So it's something that you want to make sure that we're keeping an eye on and actually repleting. Now, potassium is also renally excreted, as we know, so we do have to be a little bit more cautious, especially with our repeat dosing of supplementation in our patients that come in either with AKI or, CKD. So if you have a patient and they have really good renal function and you're putting them on a really aggressive dose of IV Lasix and their potassium's at baseline right now, I think it's totally reasonable to consider doing an upfront 20 or even 40 milliequivalents of potassium, but it's going to be really patient specific. Something else that we worry about, although we don't see as much because we kind of, have accounted for this, is that risk of ototoxicity. So it's really associated with high doses of IV boluses of these loop diuretics. So again, if you have a patient that is requiring just like so many loop diuretics per day, that's when I'm thinking about let's consider continuous infusion, because we're not going to give those really, really high doses at once. So honestly, ototoxicity is not something that I've seen in my practice, but I've worked with people in the past that have been practicing for a while, and they have patients that they can think about years ago that had hearing loss that is permanent. Something else that we think about is blood pressure variation. So hypotension, like we said before. So really for those patients, again, you may have to do slower continuous infusion instead of that quick IV bolus dosing. And then lastly, contraction alkalosis. So loop diuretics really promote the excretion of salt and water, but you don't excrete out bicarb. So you end up having a loss of extracellular fluid volume, and you really will get an increase in bicarb concentration that will lead you then to get contraction alkalosis. So that's something you want to keep an eye out for as well. The fix, if we do see it, you can use Diamox or acetazolamide, 250 to 500 milligrams daily. It's a well-tolerated drug. And it may even have some diuretic properties. It's been studied in the realm of heart failure, but those are kind of the big ones that we think about.
That's great, because when I remember going through this and going for the notes, I was like, crap, we can make someone deaf by giving them big doses of loop diuretics. And I think sometimes I hear ototoxicity, I think of that versus like, I'm going to make someone deaf. It's like, oh, okay, I got to
right? Our fancy word, but we're like, oh yeah, deaf, not good.
Yeah, it kind of just really just takes you away from the actual thing that it really is. So that's really what I try to look for, is making sure, hey, let's not give 300 at once. Maybe that's not good. And I think where this comes into play for me is when we had shortages of certain stuff, we will switch over to one diuretic versus the other and say they're on, home Bumex and I only have furosemide. That's something I have to consider as far as the transition from there, or vice versa. It was certain times we just didn't have anything, especially during COVID. It was wow. So I always want to make sure that we're making sure we account for the equivalence of these drugs first before we go over and give these super big doses. Because again, we could make them deaf.
Yeah. And I just want to plug in, use the latest heart failure guidelines as a resource. they did such a good job of having all these tables to quickly reference. So they have all the bioavailability information for the diuretics, and then they also have all the info you would ever want to know about GDMT, starting doses, target doses, doses and trials. So whoever created those guidelines really, I think, thought to make really good, easily accessible, quick references.
Now, we're talking quite a bit about these loop diuretics. How do we assess these? Because I think a lot of times pharmacists are not thinking to themselves, oh, I need to be looking at volume status. But I think it can help us with our recommendations. Can you walk us through the I's and the O's when it comes to your loop diuretics?
Yes, totally. So I's and O's, right? So interpreting volume status is, I always say, kind of like looking at a bunch of different constellations, and we're trying to see a bigger picture with all that stuff. So it's really hard to interpret volume status like intravascularly just by looking at one type of thing. So a couple of things to think in mind, or to keep in mind, is the first thing is a patient can be volume overloaded as a whole, but be intravascularly dry. So classic scenario is we have a patient coming in with acute decompensated heart failure. We get them a very hefty IV diuretic dose. They're outputting a ton. Their creatinine looks good. And then maybe, not in the ED, but on day 3 of admission, all of a sudden their creatinine starts rising, their urine output drops. But on exam, right, they're still really edematous. So what's happening in that scenario? So it's really important to realize, again, that patients can have this volume as a whole, but intravascularly, right, we are diuresing these patients too quickly, because all that volume that's in the third spacing doesn't just get automatically sucked back into the vessels as we're urinating it out in real time, right? So we have to slow down that diuresis. So that's one thing that I think that's really, really important. I think something else that is important with I's and O's is really being familiar with what they are separately instead of just the net. So, I've seen, different providers, throughout the years, or especially trainees, residents saying, they're doing their I's and O assessment and they're just, okay, they're net negative 400. Let's escalate diuresis based on that. So I think it's really important to look at what are they taking in versus what are they getting out. Because sometimes you'll have a scenario where you have a patient on a bunch of IV fluid medications, and then they're also taking a lot in orally. And let's say they're actually urinating out a ton. You do their, mils per kilo per hour calculation, and they're over 1. So in that scenario, right, we don't want to keep pushing their kidneys and actually escalate diuresis. The solution there would be decrease their PO intake of, water, and then also let's concentrate drips if we can. So that's one thing that's really a spot for the pharmacist to look at, is if they're on all these different IV meds, which of these can we concentrate? Which of these can we, maybe switch to PO at this point? Because again, it may not actually be a diuresis problem. And then lastly, keeping in mind that serum creatinine as a lab, it lags, right? So we always talk about serum creatinine, and it's not really the best marker. I think most of us know that, because it lags. So the best marker you will always have is urine output, and using kind of all your other methods to assess volume status. So I look at urine output and, again, cc's per kilo per hour. I look at how their weights are changing. If you have a provider who loves using, point of care ultrasound, they'll look at the IVC. How's it doing? Is it collapsible versus plump? That's kind of tell you about their intravascular volume status. So those are just some kind of things to look out for.
Perfect. So now that we've really chatted about assessing the volume status, once we understand that, hey, we may not be getting anywhere, if the argument is about dosing, and now we have to how do we overcome diuretic resistance? And do you have like a stepwise approach to that?
Yeah, so there's many, many different beliefs on the exact stepwise approach. And obviously, the age-old thing of no one size fits all based on the data. But our guidelines do kind of give us some recommendations. So first, obviously, being serial doubling of the IV loop diuretics to help really cross that diuretic ceiling and threshold. If you are kind of maxed out on your loop diuretics, that's when you start thinking about sequential nephron blockade. I love saying that. It just sounds so sophisticated. But we're thinking about using a thiazide along with the loop diuretic. And using this is very pharmacist kind of brained, which I love. But the whole theory is that if you're only using a loop diuretic, there is still a part of the renal tubules where you can still have reabsorption of that water. And when you put on a thiazide diuretic with a loop, you're getting both of those blocks. So you don't have that potential as much anymore. A good kind of clinical pro with this is, for thiazides, a lot of institutions used to use IV chlorothiazide as kind of their main one. And traditionally, it's a lot more expensive. There was a 2020 trial called the 3T trial that looked at, IV chlorothiazide versus oral metolazone. And they found that similar efficacy, and oral metolazone is going to be much, much cheaper. Those are really going to be your first kind of strategy. Now, as far as what to do next, I think that's where it gets a little more hairy. When we're looking at the guidelines, there's some mention of, your aldosterone antagonists having some mild diuretic properties that might be able to help. But we've studied spironolactone in really high doses. So that was the Athena heart failure trial, and we actually didn't really see improvement in outcomes. The whole drama of low dose dopamine, I don't think we want to get into too far here, but it is mentioned in the guidelines, your renal dose dopamine, with the understanding that in the overall study, really, we didn't see an improvement in urine output when low dose dopamine is added on. Sometimes when we're thinking about diuresis, it can be as simple as, let's actually add on some inotropy. Let's put on an inotrope. Let's increase that squeeze from the heart to then get more blood flow and perfusion to the kidneys. And that can oftentimes help us increase diuresis as well. So I do see that a lot, especially in patients who, they have systolic heart failure, they have poor squeeze. We're already doing all these different diuretic strategies. Sometimes just increasing their perfusion will help with your diuresis. All right, as far as other add-ons to diuretics, so there are a few things not mentioned in the guidelines that have really recently come to light in the diuresis world. So a couple of trials. So one being investigating the use of empagliflozin or MPAG-HF trial. So the guidelines were just published, and they really said at this time, the guidelines said, we don't really know how SGLT2 inhibitors will affect diuretics. But right after this, the guidelines were published, we had this MPAG-HF trial. It was really small. There was only about 60 patients, but they randomized patients to either getting standard of care with your diuretics versus adding on empagliflozin to that standard of care. And between groups, they actually did see that empagliflozin increased urine output without having much of a negative effect on renal function. There was also a good amount of patients in NYHA class 4, which is really nice to see kind of our more severe patients. So this is kind of something that I think we're just getting our feet wet with, but something that is going to maybe something that we're going to investigate in the future. Another kind of niche thing that we've started to look at is the use of acetazolamide or Diamox. So the ADVOR-HF trial was published, and they looked at, in patients that come in for hospitalization, does adding an IV bolus of acetazolamide 500 milligrams daily and improve diuresis. And the trial did find that the patients that had acetazolamide did have more successful congestion. Something to note though, so patients on SGLT2 inhibitors were excluded, so we don't really know how they work in combination. The one thing about this trial, which I think is important to keep in mind, is this trial excluded patients that required IV loop diuretics of doses more than 80 milligrams at baseline. So we weren't really necessarily looking at a true IV diuretic resistant patient population for this ADVOR-HF trial. But overall, it's a cheap drug. It's a safe drug. I would feel comfortable maybe if it was already ordered, but at this time, I'm not really going out of my way to say, let's use this for diuresis.
Those are some really good things to kind of be considered, because when we think of heart failure, a lot of us are still thinking about things probably 10 years ago versus some of these newer agents that are new kits on the block or new data on the block. And what I like about cardiology, you guys don't do studies with 50 people. You don't do studies with 100 people. You guys are 1,000, 10,000, 100,000 people.
Yeah. We got the big guns.
Studies. Yeah. So shout out to everyone who's doing those studies, because we're doing a randomized controlled trial at our shop that's pharmacist led, and they are stressed. So
I'm sure a lot of work.
shout out to Taylor and Morgan, who's really, on call 24/7. So we've really talked about diuretic resistance and kind of overcoming those. And those are the things that I think all of us are aware of, but you threw in some different tricks and some new things to really help us out. Now that we've talked about the diuretics, in what instances do the guidelines recommend the use of IV vasodilators and why? 'Cause this is going to blow people's mind.
Yeah, so IV vasodilators, when we're specifically talking about our nitrates, right? So I think these are agents that are commonly used in heart failure, and I think most of the time is very appropriate. But it's very, very interesting because if you look at the guidelines, there's actually no data supporting that they're really durable or making outcomes change in either rehospitalization or mortality. So the guidelines really recommend using these IV vasodilators for symptom control, right? So as an adjunct to diuresis. So the classic example is a patient coming in, they're super volume overloaded. We start them on IV diuretics, but that's not like all of a sudden they're just going to urinate out all their volume. That would be dangerous. We already talked about this. So what can we give these patients in the meantime to help with, their shortness of breath and all their pulmonary edema? So that's where the nitrates come in. The nitrates, especially nitroglycerin, really work on the more venous side of things. They dilate out those vessels. So they're going to reduce preload coming to the right side of the heart and decrease that pressure within the pulmonary system. So that is going to help your patient feel better very quickly because they're going to have, reduction in that pulmonary edema quickly. But it's not going to actually treat the underlying cause. That's what your diuretics are going to do.
So we have those, and I think for a lot of us in the emergency department, we only think about nitroglycerin when there's very high blood pressure. And we always talk about escape, sympathetic, crashing, acute pulmonary edema. And we think a lot of it for really, if your blood pressure is over 200s, we can talk about it. But we don't think about it, I would argue, much at all when you have those patients that are normotensive. Again, in that, I say the sweet spot of like 120s to 150s systolics is still maybe beneficial, it appears to me, in some of those patients, again, in the right patient if we're doing all the other things. Now, we have those. What about the big guns, the big inolators or the inotropes? And I think people are very comfortable with those. These are the two big ones are miranon and dobutamine with different mechanisms of action, to be honest. How they're similar and how are they different?
Yeah, so when we're thinking about our inotropes, we, like you said, dobutamine versus milrinone. So a couple things we kind of think about between these agents. So one, they have slightly different mechanisms of action. So dobutamine works right on that beta-1 receptor in the heart. And so the first thing you want to consider if you ever have a patient on dobutamine is, please, for the love of God, they better not be on a beta blocker, right? Because that is completely different mechanisms of action. So that is one thing you can assess in their profile. The main difference as far as clinical effects that we tend to see is that, the way I learned milrinone even in school was it's an ionodilator, right? So because of its mechanism of action being different, it actually causes decrease in SVR, it causes vasodilation. So in some patients, that could be great, right? So if they're hypertensive, if they have systolic heart failure, this not only helps their heart squeeze, but decreases that afterload. So it makes it easier for that left ventricle to pump that blood out. The other thing that we think about with these agents is how are they eliminated? So milrinone is renally eliminated and dobutamine is not. So you do have a potential with milrinone, especially in patients with worsening renal function, for accumulation to actually happen. The problem with that, right, is if accumulation happens, these patients can get hypotensive, and then turning off that milrinone is not going to help you because it's already accumulated. You're going to have to wait for that to kind of, get out of the system. Kind of along with this, milrinone has a much longer half-life, like about 2.5 hours, whereas dobutamine is really kind of quick on, quick off, 2 to 3 minutes, which, side note, is why you never see dobutamine as a home IV inotrope, because that would be not good sauce, right? If all of a sudden the IV bag have an issue and then you're talking about a half-life of 2 to 3 minutes, not good. The biggest side effect you're really going to see with both of these drugs that we always worry about with inotropes are your tachyarrhythmias. We're trying to make the heart squeeze more, and we're probably going to piss it off, right? It doesn't want to work harder. So tachyarrhythmias are very, very common with these agents. This is kind of an age-old question between milrinone and dobutamine, which one has a higher incidence of tachyarrhythmias. And all the data really suggests that there is not one clear choice over the other. So everyone's going to have a different opinion. Oftentimes what I do see is that the provider might, use their inotrope that they're most familiar with, comfortable with. And then if a patient gets tachyarrhythmias on that, they'll then trial the other one. But no clear benefit over one or the other. My personal preference is dobutamine. I like that it has a really short half-life. I like that it doesn't accumulate. But a lot of people are unsure about that tachyarrhythmia incidence between the two.
Yeah, if you get yourself in some bad shape, and I tell people in the emergency department, you are too ADHD to have milrinone. I'm not going to stock it. I'm not going to do it. I'm not going to have it there, because the moment my nurse doesn't see improvement in like 5 minutes, she's going to be like, click, 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 click. We don't do that. I think about the Black Panther. Was like, we don't do that here. And rapid titrations of milrinone makes no sense. But people get upset and they want to do something. That's why I tell people, I'll get you dobutamine all day. If you know what you're doing, the ICU can come down. They can play with it. If a patient's on home milrinone, when I was back down south, we had a lot more home milrinone. Up here, I've seen a lot more home dobutamine. So I think it's a little easier to kind of think about it now. But that's one of the things I'm always saying. Like, it's too short of a half-life. So like continuous infusions, all that good stuff. So I like to make sure that people are on the same page with that. But again, as you probably see things differently, it's probably makes more sense to have home milrinone, because when that thing gets turned off, you got a few minutes versus you got a couple of hours, because that can be bad. I get very scared. A patient comes in with a home inotrope or home prostacyclin. Those are the two things.
Prostacyclin stresses me out for sure.
I literally call my folks like, hey, I got this patient down here. I'm gonna try to put this order in, but it usually takes 30 minutes. It takes so long with the cassettes and this and that. And if you're not using Epic, forget about it. It is stressed out.
Yeah.
Okay.
We're Cerner at my institution.
I miss Cerner again. It's some things you can do that's nice with it, but it's some things that in Epic it just happens like that instead of me having to customize and put everything in. Yeah. Okay. We went through the big agents and the big ones. One thing I want to make sure I kind of touch on is, what's your opinion on phenylephrine? Because I just want to hear it out your mouth.
Yeah. So phenylephrine, right? It's not a first presser that you usually see regardless, but I always kind of joke to my learners that I pretty much never want to see phenylephrine ordered on any heart failure patient, especially systolic heart failure. I always say it's kind of that one presser you should avoid at all costs because of its mechanism of action, right? So it only works on alpha. It causes that peripheral squeeze to really go up, and then it causes that increase in afterload. And it's not helping the heart out at any point, right? So it's not helping the squeeze. It's just making that afterload higher, making it harder for that already struggling left ventricle to pump the blood out. So phenylephrine is a no-go from my point of view in these patients.
I remember thinking back in residency, I used to always make a joke, and the American Idol, and of course, I feel like we're dating ourselves again. I used to always be, it's a no for me, dog. If they want to order,
Randy,
it's a no for me, dog.
For sure.
And I remember a story where I was in the CCU doing PGY1, and somehow, some way, someone ordered phenylephrine really quickly because they was going to do a procedure. They want to have a little bit of something on the background. And I remember leaving the unit to go because it was the evening and we was covering multiple units. And I was like, no, man, I could just get you some norepinephrine. So I was like, I'm just going to not verify the order and just go so they can get it out. The nurse overrode it, cut it on, and I'm walking back and I hear in the elevator, it's like, code blue. And I'm like, what happened? He was like, what's the last drug you gave? phenylephrine. I was like, what?
Yep. And then that's how we remember these things, right? For sure. I feel like a lot of people, especially who have practiced for a while, sometimes it's trial and error, and that's what's going to make it stick in your head forever.
Listen, I would never forget that patient being there, being kind of sick. It was like placing a line for something. They want a little bit of something in the background. And that little bit of afterload kicked that left ventricle's butt, and it went to sleep. So, all right. So we went to the big things. Let's move over to like some more ED specific pearls. What are some things to keep in mind about how acute decompensated heart failure affects either the PK or the PD of medications that we use in the emergency department?
Yeah, I think it's an interesting question when we're thinking about heart failure and acute decompensated heart failure. Congestion that these patients have and that volume overload combined with that low ejection fraction can really affect the clearance of a lot of our meds. And then on the other side, we also have congestion in the liver and all these different things. So the big one that I see, I mean, we don't see as many warfarin patients now as we used to, thank God, because, I feel like no one loves dosing warfarin. But if you do have a cardiac patient that comes in on warfarin, oftentimes they come in with acute decompensated heart failure. Their INR will be super therapeutic, right? And then oftentimes the team wants to be really, really cautious, especially at discharge, to change their dose and make it lower than what it was before. I think the important thing to kind of think about is when patients come in with this liver congestion, with this volume overload, they are more sensitive to warfarin. But as we're diuresing them, as we're getting rid of this liver congestion, really they're getting back to their baseline. So once that congestion clears, you really shouldn't be changing the dose that much unless you had issues prior to being admitted.
And when it comes to like some of the other medications, again, are they going to be absorbed the same? Because again, I think sometimes we have these heart failure patients and we think about other especially when they're sicker, how does that impact like our absorption of some of the other PO meds?
Yeah, so oftentimes, depending on the severity of cardiogenic shock, right, if these patients aren't perfusing, we often should opt to use IV instead of other routes, especially like sub-Q or even PO. So patients that come in with a ton of volume overload, their gut will also be edematous. And this is a big problem. And this is why patients tend to come in with these exacerbations because, their oral Lasix is not getting absorbed because they have this gut edema. And then it's just this terrible cycle of then it gets worse and the gut edema gets worse and it's still not, absorbed. So, depending on the severity, there's some things that you can kind of consider. So if you're having to give insulin, you might want to opt for doing insulin drip. If you want to give an anticoagulant, if in a patient that has, really poor perfusion, do heparin, do a drip, you can easily monitor it. And then always keep in mind that when patients come in, sometimes with AFib, sometimes these patients, it goes hand in hand, heart failure and AFib. But keep in mind that if they have systolic heart failure, so if they have low ejection fractions, it's super important to avoid your non-DHP calcium channel blockers. So our verapamil and our diltiazem. Those are contraindicated in these patients because they're just going to further depress the inotropy and the squeeze. So they're just going to make the situation worse.
Yeah. You give your patient one of these drugs, especially, again, DILT. I had a patient they gave it to, and we put the patient on ECMO. And it just happened. It was like, I only gave this the fixed doses. And I was like, fam, if that EF is low and you think that patient's congested, now, is it the heart failure that's causing that versus the AFib? That's not my determination. However, if you're concerned about it and they are decompensated in any kind of way, you're going to potentially make a bad decision and you probably shouldn't use those drugs. So that's one of the things I always say. You probably want to, think twice about that. So now let's transition to really, I would say I had a boss, her name was Sarah Harrison, and I used to always be really good at kind of the big picture, putting things together pretty quickly. And she would say, Jimmy, you just do that and I'm gonna get it pretty for committee. And and that always stuck with me when it comes to packaging people up. And when I think about these heart failure patients, I want to figure out how can we get them ready for committee. Now, not all loop diuretics are the same. You have bumetanide, furosemide, and torsemide. How do we choose these to really get us there?
Yeah, so I'm sure everyone is aware Lasix or furosemide has kind of been most people's mainstay. So looking at the data, about 87% of patients are going to be on Lasix or furosemide. It's cheap, it's easily accessible, so oftentimes it's going to be your first thing that you think about. However, when we're actually looking at the PK, PD, bioavailability, all that stuff of our other loop diuretics, bumetanide and torsemide have much better bioavailability when we're talking about them versus furosemide. I don't like using the term that they are stronger diuretics, right? Because dosing wise, they're more potent. But really, if you have a patient who continually comes in with volume overload, even though you're getting them on their oral furosemide, something that you can consider is, can we switch them to bumetanide or torsemide? Because in those scenarios where you have that gut edema, they might perform better than furosemide.
Now, we're looking at our conversions. I always remembered it as 1-2-4, and it may not be the best way to think about it, but like, of course, one of Bumex is 20 of torsemide, is 40 of furosemide, and remembering that that's IV. And I think when we mentioned that the high variability in the high variability in the bioavailability, I think when I look at it and I see 10 to 90, I'm like, what?
Yeah, we have no clue what's going on.
Like, what? Like, what is going on? It may be this much. So like half the dose is just like, I think that'll work.
Uh-huh.
As
For
we go
sure.
from there. But I think I want to go back to some of the foundations, and this is a really get pretty for committee moment here. What are the four classes, the pillars of HFrEF, and why are they important?
Yeah, so when we're thinking about the four pillars of GDMT, we're thinking about ARNIs, ACEs, ARBs as our first one. Then we're thinking about beta blockers, and there's specific ones we'll talk about. We're thinking about our MRAs like spironolactone, and now we have our SGLT2 inhibitors. The guidelines really, really nicely laid down why GDMT is so important in this latest rendition. I feel like it's almost like a mic drop moment for people that they can use, especially as pharmacists, right? You show the physicians, you show your team, look how important these drugs are, right, in the guidelines. So even the guidelines, this is a quote, right? So the use of all four drug classes has been estimated to reduce all-cause mortality by 73% versus no treatment. When we're thinking about number needed to treat, same thing here to prevent all-cause mortality. It's fantastic. So for example, for MRA, you just need to treat 9 patients over 24 months to prevent 1 death. So GDMT is super, super important, but a lot of our data suggests that we're kind of failing at getting GDMT on board. So, the guidelines, again, spell this out really nicely, but there's been data looking at this, and nearly half, so 46% of patients that come in with systolic heart failure and are hospitalized for it, at 12 months, they have no changes to their GDMT. 42% are either on no GDMT within 30 days, and at 1 year, 45% of patients are either on no GDMT or just one agent. So a nice quote from the guidelines says, it says, it cannot be assumed that oral GDMT will be initiated or optimized after hospitalization for HFrEF. So they spell it out really nice. Oftentimes you hear from the team, like you said, oh, we started outpatient. The guidelines acknowledge this, and they literally say, you can't assume this because we have plenty of data showing that this does not happen. And they actually endorse that hospitalization for heart failure is a really important time frame to actually, one of our goals should be getting GDMT on prior to discharge.
It's amazing to think about this, because we went from a lot of strong opinions of just like holding and preventing all these things to like, no, 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 no. You need to be the one starting these things. You need to be the one who's the initiator of these. If your heart function allows you to do so, you need to get these things on board. So Another thing that comes up, I think that can catch people off guard is the ARNIs. And even me saying that is unique because I remember when it first came out, I had a professor, Dr. Miller. He was so excited about the release of Entresto. I would never forget that. And my last rotation was at a heart failure clinic, and he was talking to a patient, and we was talking about diet. And I always have these random stories that make me remember these drugs. But I remember talking to her about, like, salt and things of that nature. And she said, "What am I supposed to eat?"
Yeah, especially if they have heart failure and CAD, right?
Yeah. And so my professor's like, "You can eat this pill of Entresto, you'll be fine."
Oh my God. Fantastic.
So when speaking of the ARNIs, there's oftentimes a great board question, but what is this transition? Because most of the time I had a team ask me last week, "Hey Jimmy, I see the patients on ARB and this new drug. Like, should they be on both, or is there some type of transition?" Can you walk us through the transition of these different our old time agents with the ACEs and the ARBs to the ARNIs?
Yeah. So when we're thinking about ARNIs, they come with a pretty large risk of angioedema, similar to our ACE inhibitors. So when we're thinking about ACEs and ARNIs, both of those drugs, based on their mechanism, increase bradykinin. Bradykinin is going to be that peptide that causes things like angioedema. So because they both, cause bradykinin levels to increase, that's why, firstly, you'll never see, a neprilysin inhibitor co-formulated with an ACE. And this is also why we have to have a washout period when we're transitioning from an ACE to an ARNI or an ARNI to an ACE. This does not apply to an ARB. So if a patient was, just on valsartan or losartan, they can just go ahead and start their Entresto when the next dose is due. But if they are on an ACE, they need at least a 36-hour washout period before starting their ARNI, and vice versa. And that's really to reduce that risk of angioedema. Now, technically, it's a 36-hour washout period. I'll be honest, if I'm talking to patients in clinic, to make it easier for them, I just say wait 2 days, right? Yeah. Instead of like 36 hours can be confusing for a lot of patients, but that is kind of your bare minimum.
Perfect. We've really covered quite a bit of these, and I want to really kind of transition, if you could talk about the HFpEF, because these are going to be all of the agents that we chat about quite a bit. But is there a ranking of these agents when it comes to HFpEF? So like the HFpEF GDMT ranking, like what is the guidance on that? Because I remember way back when, I remember just my preceptor saying, "Jimmy, I'm gonna be honest, we don't know. We don't know." But I think today, many years later, we have a better sense. And what does the guidelines say when it comes to the agents for HFpEF?
Yeah, and I think it's kind of funny because we've made so many strides in our HFpEF treatment. I always tell my students, like, when I learned HFpEF, the guidelines literally were like, treat underlying causes. If they have hypertension, treat it. Like, there was no clear treatment. But I do think that the data behind HFpEF is still kind of a little spicy, and there's a lot of controversy in the cardiology world. When we're thinking about HFpEF management, the clearest agent where we have the cleanest data for is your SGLT2 inhibitors. Mm-hmm. So that has the highest level of recommendation in the guidelines. So that is definitely the first kind of agent for GDMT that you should be reaching for in your diastolic heart failure patients. Now, per the guidelines, if you look at what is recommended next, these 3 agents all have the same level of a class 2 recommendation. That's going to be your MRA, your ARNI, and then your ARB. Here's kind of where the drama ensues when we're talking first about your MRA. So just like for spironolactone and heart failure, we had in HFrEF, we had a trial looking at that. That was the RAILS trial. They also repeated that in HFpEF. So that was the TopCat trial done in 2014. Again, seeing if spironolactone can help these patients out. So just like every other trial beforehand, I do think it was kind of disappointing when the results came out. It found that in these patients that have HFpEF, we really didn't see statistical significance in that primary endpoint of CV death or hospitalization or cardiac arrest. But if you actually look at the separate primary endpoints, we did see some benefit with heart failure hospitalization. So it wasn't fantastic, but we're like, okay, at least we found something with this. We can say that it decreases hospitalizations. The drama comes with that, this was a multinational study. And so there was a lot of cohorts, but one of the biggest few were in North America and then in Russia and Georgia. Someone looked at the data post hoc and they said, there seems to be some regional, variations between how patients did in these different regions. And so that was published post hoc in 2017. And they really looked at how did patients in the TopCat trial do in North America versus Russia, Georgia. In North America, they reached statistical significance and it was beneficial in every single endpoint. And in Russia and Georgia, we didn't see it in any of the endpoints. So then the drama ensued, and someone looked at the metabolites of spironolactone in these different patient populations. So that was published again a couple years later, and we found that in Russia and Georgia, 10 times higher amount of patients did not have any detectable spironolactone metabolites in their blood. So this is a very kind of dramatic trial, right? In cardiology, you'll have people who are either MRA believers or non-believers in HFpEF. I personally think that at a minimum, we know it reduces hospitalization. And I actually do have some faith that I think it does more than that. Next, when we're thinking about our ARNIs, again, I want to be clear that the guidelines really recommend this the same as your ARB and your MRA. But what I do want to say is that when ARNIs were studied in HFpEF, that was the Paragon HF trial, when we looked at how it did in diastolic heart failure, people were really excited to study this drug because it totally rocked in HFrEF. When we looked at it in HFpEF, it actually did not reach its primary endpoint of hospitalization and death from CV causes. And it also didn't meet any statistical significance in any individual outcome. So I love showing my learners, there's this 2019 article that was ARNI flops crucial heart failure trial, imperiling $5 billion sales goal, right? So everyone was super disappointed that we didn't see statistical significance. But fast forward a couple of years in 2021, there's an article saying, Entresto wins first ever FDA nod in hard to treat type of heart failure. So when we're thinking about it, our ARNI was the first ever FDA approved med for HFpEF. But, whether or not it is that beneficial, I think is very controversial because in that large trial, we actually didn't see benefit. Lastly, for our ARBs, I think that's also kind of very interesting because if you read the text in the guidelines under the ARB recommendation, it quite literally says we didn't see any benefit, even though there's this kind of hypothetical, maladaptive RAS activation in HFpEF. When we're looking at the trials with ARBs, we actually didn't see benefit. So long story short, HFpEF treatment is a little controversial. Definitely put the SGLT2 on first. After that, it's kind of dealer's choice. I personally think it should be MRA first, and then ARNI, and then ARB. But really, the guidelines say that MRAs, ARNIs, or ARBs are all kind of your second line agents.
Perfect. And it really ties pretty nicely to kind of wrap things up because I think we feel so helpless in HFpEF, to be honest. And the ED folks are sitting back, and my critical care people are like, when should I restart this? What should I do while they're on this? Is it the same benefit? And it's probably not the same benefit yet. It seems like there's some pretty interesting stuff going on in the drug manufacturing process and the clinical trials in Russia and Jordan. They just happen to found this new way to make the drug where it just don't have metabolites. That's phenomenal.
Yeah, right.
And it just didn't have the benefit for some random reason. But hey, I'm just a podcaster here.
We just work here in the hospital, right?
Yeah, we don't know. But let's just close things up. Again, any things you want to kind of just keep in mind as we're going about our shifts, whether we're inpatient, whether we're outpatient? What are some things you want to leave the audience with when it comes to the management of all types of heart failure, whether it's Mr. Heart Failure or improved heart failure or deproved heart failure? What's some things you want to leave the audience with?
Yeah, I think the biggest thing is always going to lead back to GDMT. It's something that we talked about a lot today, and there's a reason for it, right? These drugs make a staggering difference, especially in systolic heart failure. I think something that is important to keep in mind is that we're not treating hypertension in these patients, right? So I see this all the time, and I think it's very widespread, especially, with non-cardiologists, but they'll see a patient who is normotensive, like 120 over 80, and they're not optimized on GDMT, and they'll say, I don't want to add an ARNI, I don't want to add an ACE because they're not hypertensive. Similarly, right, these patients, systolic heart failure patients, like I said before, sometimes tend to have really low systemic blood pressures, right? Because they can't really get that systolic blood pressure high because they have poor contraction. So a lot of these patients will kind of look hypotensive at baseline, but if you actually look at their map and how they're perfusing, that's just kind of where they sit at. And so again, really the guidelines say that, you have to get to target dose or max tolerated. So it's not enough to just have low blood pressure numbers. If your patient is actually asymptomatic, you want to continue to up titrate, right, until they cannot tolerate further up titration or they're at target. So again, I know it's corny, but GDMT, it saves lives. It's super important. And data shows that we're failing at getting these on board in these patients.
That's amazing. We just have to really get on board with I call it reverse stewardship, getting these things on and using them when we need to. But for our audience, I want to kind of summarize some of the things I've taken away from this entire episode. The one big thing is 46% of heart failure patients have no GDMT changes 12 months post-discharge. That's wild to me, half of the people. Also remember to start at high doses using the dose trial, 2 to 2.5 times that home dose, but as IV. Keep your K above 4 in all of these patients. Avoid all of the fluids. Again, that's something we can probably be having a mistake with. Never use phenylephrine in these patients, particularly those that in cardiogenic shock, because it makes no sense for us to do that. Remember the 36-hour washout between the ACEs to ARNI, and you don't have to worry about that going to your ARBs. Switching to your PO diuretics 24 to 48 hours before discharge can be great. A small rise in creatinine doesn't mean stop diuresis. There's a lot of more work to be done. Avoid your diltium verapamil in these patients with HFrEF, with AF, and low blood pressure is okay if asymptomatic. Push GDMT. Is that pretty much it?
I think you nailed it. I think we can just summarize it like that.
So, Cait, thanks for coming onto the show. This has been phenomenal. For our listeners who want to know more about heart failure or just want to follow your work, where can they find you?
Yeah, so like you mentioned in the beginning, I do have a cardiology teaching blog, I like to call it. I made it actually for mostly my learners on rotation, but it kind of, has grown since then. But that's cards.rxexplain.com. And I cover a bunch of different cardiology topics. So, AFib, arrhythmias, heart failure, ACS. So if you ever want to read on the blog, I try to keep things very low key, a lot of memes. I don't take life too seriously. So it's not much of a dense read.
Perfect. Well, again, we also just really appreciate the expertise coming on and really just nailing down some of these things, whether some of this is a refresher for some of you, or if you thought you knew, but you didn't know, this is also going to be great. And we're going to go ahead and just close out the show. Remember, Pharm So Hard, again, every acute decompensated heart failure patient is an opportunity to optimize GDMT and prevent the next admission. You got all the tools, so go ahead and save some lives. And I close out every episode the same way. You don't have to be a pharmacist. You don't have to work in the ED, but everything you do, make sure you Pharm So Hard.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.